Hello folks, welcome to another SACPA session. SACPA acknowledges that this event takes place on the lands of the Blackfoot people and the Métis Nation of Alberta Region 3, and we pay respect to their past, present and future cultural heritage, beliefs and relationship to the land. SACPA is very thankful for the continuing support we receive from the University of Lethbridge, Shaw Spotlight and the Lethbridge Herald. Today, we're very happy to welcome Leah Odell-Benson, Deputy Director and Impact and Learning at the Stephen Lewis Foundation. The Stephen Lewis Foundation is a progressive feminist organization rooted in the principles of social justice, international solidarity, and substantive equality. The Stephen Lewis Foundation was created with the express purpose of supporting community-based organizations working on the front lines of the AIDS pandemic in sub-Saharan Africa. Many of these grassroots organizations were originally formed by small groups of individuals responding to the crisis of AIDS that had wrought in their own lives and in the lives of their neighbors. Over the years, they have developed into a thriving local institution or institutions with deep connections to their communities. The Stephen Lewis Foundation community-based partners are turning the tide of HIV and AIDS by providing care and support to women, orphan children, LGBTQI individuals, grandmothers, and people living with HIV and AIDS. Thank you so much for joining us today, Leah, and look forward very much to your presentation.
Thank you so much for having me. It's lovely to be here with you, and thank you for that lovely introduction. Again, my name is Leah, and I'm calling in from Ottawa, which is the unceded territory of the Algonquin and Anishinaabe. I'm in Ottawa. The foundation itself is actually in Toronto. So I'm going to just start this presentation by just talking a little bit about who we are as a foundation, because who we are matters. It's core to our values and the way that we work as an organization. So if we could just go on to the next slide, that'd be great. Thanks. So, thank you. So about us, we were created in 2003 with the expressed purpose of supporting community-based organizations working on the front lines of AIDS in sub-Saharan Africa. And our founder, Stephen Lewis, when he was the special envoy at the height of the HIV and AIDS pandemic, he was the special envoy for UNAIDS, and he would go out to sub-Saharan Africa and realize the people doing the work weren't receiving the funds. People at the front lines weren't receiving the necessary funds or recognition for the work that they were doing to cut HIV and AIDS off at the root. And so he and his daughter Ilana started the foundation in 2003, and it's grown tremendously since then. We're now an organization of about 30 staff. And why were these organizations not getting the funds? Because of geopolitics and racism, essentially. Funding just was not making it directly into the hands of those actually doing the work on the ground, and there's a lot of geopolitics wrapped up in that, especially in conversations around Africa and African context. A lot of conversations around colonialism and colonial understandings of the work that was happening in sub-Saharan Africa. Where funds were being shared, they were really prescriptive and restrictive. They weren't flexible. And both Stephen and Ilana had a really deep understanding that positive and lasting change can really only happen through solidarity. Not through charity, but through meaningful solidarity with those most affected at the community level. And the community-based organizations were the ones who knew these people the best. Not the intermediary NGOs, but the community-based organizations. So next slide. So we have 121 project partners in 15 countries. And as we mentioned before, we're working with children and adolescents, grandmothers. I hope many of you are familiar with the grandmothers movement. In terms of how iterative the foundation has been in understanding the needs on the ground. When the foundation first started, we would get all these requests coming in, and these these narrative reports about the caretakers, the caretakers, the caretakers. And when we dug a little bit deeper, we realized that the caretakers were grandmothers. There were grandmothers who were caring for the children that were left behind when their parents died of HIV and AIDS. A whole generation essentially wiped out. Grandmothers who were, in the prime of their lives, coping with their own grief and loss, and also now expected in their years to care and provide for young children. We also work in the area of home-based care, which is an evolving form of community-based care, in positive living, which essentially is, working in issues around stigma and discrimination and advocating, ending violence against women, and most recently LGBTIQ health and human rights. We have 16 LGBTIQ partners that we work with across Uganda, Kenya, and Tanzania. Next slide. So who are we? This was shared a bit, so I'm not going to go over this in any great detail, but I want to share that, again, who we are matters in terms of the work that we do and how we do it. We have strong values of anti-oppression and anti-colonialism. We have a partnership model that's really infused into the fabric of our day-to-day work, and we acknowledge the power that we have as a funder sitting in an office in Toronto, and the imbalance that creates, right, when you are supporting community-based organizations. And so we really try to develop and work with models that disrupt the legacies of racism and structural inequality that exist in international development now, which means essentially that we don't have projects. We don't run programs. We're very much guided by the work that's happening that the partners are doing on the ground, the express needs of the partners, and really building relationships that are essentially made of trust and mutual respect and that are long-term. And so a bit more about who we are. Again, we firmly believe that the expertise comes from the community-based partners. We don't know what's happening in the sense that we're not there. There's that saying, who feels it knows it. And we really believe that about the context of this work. Those most affected know best what the solutions are for their day-to-day realities and challenges. It's not prescriptive or impositional, but it honors and respects partners' autonomy and decision-making. So essentially, we don't, instruct partners on what they should be doing and how they should be doing it and what the organization should look like. And we don't, kind of go in with any of those kind of prerequisites. We have a strong belief in organizations' power to create meaningful changes for themselves and be self-directed, and to walk with them over the continuum of that journey. It's their highs and lows and in-betweens organizations, just like, all of us. And so we kind of walk with them along that continuum. And so many partners we've had for 12, plus years, 13 years, we've been working with partners, and we've really seen them grow from strength to strength, from very small organizations with sustained support over years, becoming much bigger organizations and very self-sustaining. And then again, we develop relationships that are extremely flexible, and it's based on the expressed needs and the priorities of the partners. So next slide. And then again, this is more about, who we are. So I think the long-term piece is the piece that I really want to get across here, and that, we don't believe that sustainability comes from funding a one-off project. This work is long-term. It requires long-term commitment. It's not a linear journey in terms of models of success. There are ebbs and flows and highs and lows for both the organization and the impact that they're able to have based on country context. COVID has been a very good example of that. And it requires a relationship that's based on patience, perseverance, commitment, authenticity, understanding, and reliable funding. And that's flexible funding as well, which supports core costs for organizations, things like salaries and rent. Partners cannot do this work meaningfully if their core costs are not supported. And one of the biggest challenges, I think, in HIV and AIDS funding as it exists to date, is that people are very willing to fund projects, because projects look very good, but they're not willing to fund salaries or rent or utilities, those things that keep organizations running from the day-to-day. And why does any of this matter? I mean, we've come a long way There's been momentous progress in the number of people that have been on treatment. Antiretrovirals are now much more readily available than they were in the early days. But inequalities still persist, and 6 out of 7 new infections among adolescent girls are in the sub-Saharan region. Gender-based violence continues to be very real, and inequalities in terms of accessing resources, accessing health services, accessing spaces that are stigma and discrimination free in the context of folks living with folks who are identified as LGBTIQ is extremely difficult in the countries in which our partners work. Many of our LGBTIQ partners work in contexts where the law does not support them and their rights. And so, there's much to contend with in the context of inequalities and how that exacerbates and exaggerates the context in which partners live in. And then also, the vast majority of people living with HIV and AIDS reside in low and middle income countries, and yet the funding to those countries has decreased over the years, which is, increasingly a problem. And again, I kind of touched on this already, that when funding is available, it's just not making it into the hands of community-based organization, and it's too often constrained in ways that limit the effectiveness of the funds and limit the effectiveness of people able to deliver those funds in meaningful ways. So next slide. And then, we've been kind of touting this line for a really long time now about the importance of community-based organizations. And finally, we feel like the international community is kind of caught on to this, UNAIDS, other facilities of the United Nations, recognizing wholeheartedly that all of the progress made has been because of much of the progress made anyway has been because of community-based organizations doing the work on the ground. People who have close personal relationships and close professional relationships to their clients and to the beneficiaries, people who the beneficiaries trust, people who know the context of their communities and are able to develop and devise programming that aligns with that context and is agile enough to adapt when that context changes. And so, we're really proud to say that, finally we feel like the international community's got on, though that is not met by increased funding. So there is the disconnect. Okay. And so why do we believe in investing in CBOs? Again, we believe that healthy community-based organizations are essential for building strong and resilient communities. That CBOs know their communities best. They are of the community, for the community. Many of the organizations we work with started out of necessity. You have organizations that were started by a teacher who recognized a particular need in his community around adolescents and orphans and vulnerable children in terms of not accessing school, and decided to do something about it. We have LGBTIQ activists who decided to do something about it. And so, most of the organizations and many of the organizations were started out of necessity, that were started in community, and they just grew and grew because the need was so great. And I think there's a lot of merit to that kind of approach and understanding that comes when organizations are not just in community, but of community, that are made up of community members and of active engagement of people living with and affected by HIV and AIDS. They develop deep and lasting connections with their clients. There's a level of trust that is built because of this continuation of the work over time. And they're in tune with their community's needs. And I'll tell you a bit of why that is in the next slide. And I think it's, because community-based organizations provide a continuum of care that is so difficult for other, institutions to do. So they recognize the intersections of people's lives. We're not just one identity. We make up multiple identities. We have multiple needs. And when we think about the social determinants of health and all the things that impinge and impact upon us accessing meaningful health, there's so many pieces of that, right? And so because community-based organizations are focused on a human-centered approach, they can make the referrals. They can, assess the situation. They can treat the whole person. It's very difficult to go on antiretroviral medication if you're not accessing food, if you're not meaningfully employed. It's very hard to advocate for your rights if you don't have the necessary psychosocial support services. that can, or to adhere to your antiretroviral treatment if you are not working with peers who can motivate you to and support you. So I think it's this kind of wraparound approach to doing that makes it especially meaningful, and it's very unique. And I know that we talk about the social determinants of health all the time, but this is the way that community-based organizations have been working for a really long time. That the whole person matters. You're not some pieces of in this case your HIV and AIDS status. That you are many other things, and these things matter, and they matter to the organization that is supporting you. I also will say that the other piece that really kind of speaks to me is that people exist in families, and another thing that community-based and communities, but in family, and so community-based organizations are actually able to assess the needs of the family as well, because it's very difficult to work with one person in a very specific context, and through things like home-based care, which is the next, which is a program area that our partners have worked in for a very long time. Community-based organizations can assess the need of the family. And so, home-based care has evolved over the duration of the HIV and AIDS pandemic. Now it really is about meeting people where they're at in terms of their access to health. In the context of sub-Saharan Africa, it's a very geographically spread place. 13 of the 15 countries that we work with, I think there's fewer than 3 doctors for every 10,000 people. So access to kind of medical facilities is just not feasible or realistic. The cost of transport is prohibitive. There's still a lot of stigma and discrimination that exists in national health facilities. And so community-based organizations have set up, home-based care, essentially community-based care settings where community members can feel safe, accommodated, and where the needs of the whole family are adjusted and spoken about, right? So you can go into the home and understand if there's a context of gender-based violence that's happening that's preventing someone from access, from adhering to their antiretroviral treatment or preventing a child from going to school. I think that the merits of home-based care as an approach have been significantly underrated by the HIV and AIDS response. Home-based caregivers are so essential to supporting those living with HIV and AIDS in their journey, in their life journey, and walking with them along that continuum. And so this is an example of kind of one of the areas that some of our partners work in, that we are continuing to highlight across the organization, because we've recognized how, I would say, 60% of our partners work in this way, if not home-based care, in a community-based setting. And the referrals that they're able to make to mainstream health facilities and the connections they're able to bridge, and the way they're able to bring people into the healthcare setting through this kind of one-on-one support cannot be overrated or overstated. And so this is an example of a home-based care worker, and many of these folks are volunteers, which is the other travesty, right? Is that, and many of them are women, right? And when you think about women's unpaid care responsibilities, gender roles, and this is inherently problematic, right? Because the HIV and AIDS response is not compensating women for the work that they're doing in community building, especially in the context of home-based care work. And many of these home-based care workers are essentially beneficiaries of the organization, who came to the organization and who now want to continue this work. And they're so critical to the work of the foundation. And they essentially go into community to provide all these kind of routine vaccinations, monitoring ARV adherence and wellness, delivering food, providing support to education and health, postpartum support, bathing clients, and delivering medicine. And that's largely done by volunteers, because small communities, they cannot afford to pay the salaries for these individuals. And the foundation really believes wholeheartedly in advocating for flexible funding so that that people can be compensated for the work that they are doing, and that national governments actually recognize the essential role that community-based health workers play in the wider community-based healthcare setting and in the national response more specifically. Okay, and this is just a nice quote from one of our partners, St. Francis Healthcare Services. They are in Uganda. And it just says home-based care allows us to deliver comprehensive, holistic care to the community. When our home-based care team visits, treatment for illness affecting the members of the household is done. HIV testing is also done at the household level, along with counseling, psychosocial support, hygiene support, parenting dialogues to guide grandmothers with parenting challenges, and child protection dialogues to support grandmothers through creating awareness on how to access services. Okay, next slide. And grandmothers, we spoke a little bit about grandmothers. This is another one of our key programmatic areas, because grandmothers are a movement now across sub-Saharan Africa. They are advocating and lobbying for their rights, their right to social services, their right to social supports. They are a cornerstone in the HIV and AIDS fight. They have been supporting the care of a generation of young people over the years. And them, while going through their own grief, they've been supporting them with parenting assistance. They've been community-based organizations responding with leadership training, with income generation. And now grandmothers are at the forefront of lobbying for their own rights. So we have a organization. The foundation works with grandmothers in Canada to support grandmothers. It's called the Grandmothers to Grandmothers campaign. I'm not sure if some folks in the room are familiar with that work, but it really is again about solidarity and an understanding of the needs of grandmothers and a recognition for the incredible role that grandmothers play in supporting communities, in being leaders in their communities, in passing the institutional knowledge and the generational knowledge that has created robust and resilient communities over time. And so this is a very important programmatic area for the foundation because many of the beneficiaries of the work that the partners are doing are grandmothers who are taking care of orphans and vulnerable children, who are having to provide school fees, who are doing all of these things, and they've really become active agents of change in their own destiny and their own journey. We continue to build and support the grandmothers movements across sub-Saharan Africa. And this is Miss Amumba at Cindy. She's a grandmother. And this little quote says, "I am what I am now because of the Grandmothers Network and the support I received from Cindy. I am amazed that there are people out there who are concerned about people who are vulnerable." And yeah, Prissa she's a widow with 4 grandchildren and 6 children of her own. And she is supported by income generating activities. She went through an income generation training to figure out how she could be economically empowered to run her own business. And so through Cindy, she's able to do that. And that then facilitates her ability to support her grandchildren and her children. And diverts feelings of isolation that evolve when you can be part of a network of grandmothers doing this work, of peers who can support you, who understand you, who know about the challenges that you're experiencing. She's joined a women's club, so these are the kind of networking pieces, the community pieces that are so essential to people's well-being, especially, as you get older and older. And so COVID-19. COVID is, I know we've all, in many ways, differential ways, but in many ways been affected by COVID-19. I know in Alberta right now you have a current spike in cases, which is putting a tremendous pressure on health facilities. So imagine when you have a population in sub-Saharan Africa, which is the case of 1 billion, the incredible strain that COVID has brought on national health responses, again, can be overstated. Health systems have been incredibly stretched. And then when you think about vaccine access and the challenges that many countries in sub-Saharan Africa have had in terms of accessing vaccines, you can see how the situation is compounded. African Center for Disease Control and Prevention aims to vaccinate 60% of the African continent by the end of 2022, which is more than a year and a half after similar targets reached in many other parts of the world. Vaccine inequity is huge. And when you compound that with dual pandemics, you can only imagine how challenging that has been for the partners. In terms of physical disruptions. It's disrupted people's access to HIV treatment and prevention commodities. I mean, transportation costs went up. Physically getting to facilities to access ARVs became very, very challenging. It reduced testing and delayed HIV treatment initiation, interrupted uptake and consistent access to PrEP, which is a pre-exposure prophylaxis. I mean, the isolation created by lockdowns also led to violence and discrimination. This was particularly evident for some of the LGBTIQ organizations that we work with. You know, it's really challenging in that context where you live and work with your chosen family, and then you are in lockdown and you have to go back to your family, who may not necessarily be as supportive as needed, into communities that may not be as supportive as needed. And so, you know, many folks really suffered tremendous challenges in the context of lockdown, the isolation, the violence that occurred when your home is not your safest space. You know, the thing with lockdown is it infers that your home is a safe space, and for many people that is not the case. There was a decreased access to income generating opportunities, which so many rely upon. You know, for grandmothers, you know, who were selling goods and services in markets, this was not, you know, an option for a very long time. School closures, you know, I think Uganda just went back to school recently. And school is more than just a physical space, right? School is access to meals, it's access to safe spaces for children. And I was reading a report recently from one of our partners, and there's a line in there that said, you know, children were falling pregnant in the context of being away from school. And there's so much you can read into that, but the challenge is extremely real. And so this is a quote from Ishtar MSM, one of our LGBTIQ organizations, which spoke to their present context in COVID. People use sex, alcohol, and drugs to cope with the stress. He also saw that HIV positive clients were struggling to adhere to ARTs when job losses made it impossible to put food on the table. Someone would say, what's the point of taking medication when I can't eat? Quite a number of them kind of lost direction. And so, you know, organizations like Ishtar and the staff at Ishtar really put themselves at tremendous risk to keep their wellness center open, recognizing that safe spaces, safe community spaces are so critical to the health and well-being of their beneficiaries. They kept those safe spaces running and operating, hotlines, phones, any kind of access that they could continue to have to their beneficiaries during this very difficult time. And this flexibility that we have as a foundation allowed them to pay for things that they wouldn't have thought they needed to pay for in the context of COVID. But you know, the reality is as well, and I know that I'm wrapping up on time really quickly, so I'm going to try and speed through. The partners were built, the partners that we work with were built in the context of pandemic. And so one of the things that we kind of realized is that they were super agile in pivoting to meet the needs of their community, because this was a reality. This is a dual pandemic. You're talking about organizations who were built in the very early days of HIV and AIDS. And so they were able to really pivot their programs and services to meet their community's needs. And that included support to immediate needs. So food, sanitizer, masks, adjusting their programs and services to more accessible online components, strengthening their community-based care systems and psychosocial support. And they became really, and continue to be really relied on by governments for a vaccine rollout and COVID sensitization and basic care. So, you know, many of our partners were physically shuttling beneficiaries to vaccine centers, to testing centers. And the government, I think, has come to rely on them extremely heavily for their reach, for their ability to reach the most marginalized and most vulnerable in those communities, where, traditional services fail, essentially. And so the SLF support has been, to these organizations in the context of COVID, has been through additional funds. We've provided additional funds to all of our partners. The flexible funding that we have makes it very easy for partners to adjust. They can say to us, this is not happening. They're not locked in. They can say, this is not happening. This has changed for us. We need to use the funds for this. And it's a very straightforward and easy process. They're not locked into a log frame or a logic model or any of those kind of somewhat constricting ways of doing this work. We just provided a lot of space for them to adjust to the new realities of this work, which was just giving space and holding space for folks, without expectation. We moved all of our M&E to virtual, and we just kind of maintain an ongoing connection with all of our partners. And it's been a real journey. And this is just kind of one of the things that our partners have done to kind of pivot their programming and services. This is Stepping Stones International in Botswana. Again, recognizing that gender-based violence increased in COVID, after lockdowns eased, they mobilized grandmothers to support them in identifying cases of GBV in the community and making the referrals that were needed. And grandmothers were able to reach some of the people that they just could not get to. And that is it. That is us in a nutshell and some of the work that we do. And we hope you can continue this conversation through our website as well, StephenLewisFoundation.org. There's lots of information up there about who we are and what we do. So thank you so very much. Yeah. And now I'm open to any questions.
Lovely. Thank you for your presentation. I'm going to jump right into the questions here. Our first question comes from Bev Mundell Atherstone. You mentioned the shocking HIV AIDS infections and death in 15 to 18-year-old girls and then in brackets, was it sub-Saharan Africa? Are these high rates contributed to by female genital mutilation?
Yeah, that was a statistic from UNAIDS in the context of sub-Saharan Africa as a region. I don't want to suggest that would be the situation. It's not something that female genital mutilation is something I'm super familiar with. What we do know is there's many other attributes, one of which is gender-based violence. The other is, very inequitable gender norms. The other is generational relationships. There are many, contributing factors to why women and girls continue to be so vulnerable in the context of HIV and AIDS. A lot of that has to do essentially with the underpinnings of gender inequality, right? Negotiating safe sex can be very challenging in intergenerational relationships. Access to sexual reproductive health education and services about how to prevent HIV and AIDS is also challenging. And so there's many kind of contributing factors that compound that issue, but all based on essentially based on inequality, right? And gender roles and responsibilities. Yeah.
Okay. Next question, again from Bethman Atherstone. We have a very active, this is more a comment, I think. We have a very active Harambee grandmothers group in Lethbridge who raise funds for grandmothers in Africa through the Stephen Lewis Foundation. So it's a plug.
That's great. Thank you so much for everything that you are doing. The grandmothers are a tremendous force that we are always super grateful to be able to support and to learn from.
Next question comes from Ian Hurdle. Have these community-based organizations been able to bypass the at times national reluctance for HIV drugs to gain access to low-cost generic drugs?
I mean, it's a really good question. I think that many of, I don't want to speak out of turn, but I think a lot of the ARV, I can't speak to medications, but are generic medications, which has driven the cost down, right? Like it's, but they do work with national governments to access antiretrovirals. It's a part of national strategic plans around HIV and AIDS to provide those things for their countries. So national governments, I think, continue to be the place and have a responsibility because of public health to provide these medications. And communities organizations work with them in support of distribution and adherence. Because it's one thing to provide medication, it's quite another thing to take it for the rest of your life. And so, that disconnect is where CBOs really come into play in that they support folks in not just taking the medications, but understanding what that looks like at all the various stages of your life. I mean, can you imagine being a young person and having to manage that process. And luckily, you know, community-based organizations are there to support with peer mentorship and peer support, you know, in support of folks continuing that ARV journey, because that's what it is. You know, it's much about behavior as it is about a medication, you know.
Our next question comes from Mark Goodall. Have attitudes re safe sex changed since antiviral drugs have become more available and death rates due to AIDS reduced? That seems to be what has been happening in the West.
Has behavior changed?
Yeah.
So the question?
Have attitudes re safe sex changed since antiviral drugs have become more available and death rates due to AIDS have been reduced? That seems to be, Mark seems to think that that's the case in the West. So has that?
Yeah, I mean, it's hard to speak to that because, you know, sub-Saharan Africa is not a homogenous place. It's made up of various countries with very specific national contexts, very different economies and political contexts, and those things have an impact on people's lives, conditions in which they live, whether, you know, have an impact on their lives. And so, you know, maybe knowledge, attitudes, and practices have been shifting over the years, but there's still some very discriminatory practices and attitudes that remain and, you know, and persist. Many of them are around gender and inequality, and that, you know, affects access to resources, to economic resources. So things compound. It becomes less about just your knowledge about HIV and AIDS and navigating all of the other obstacles that you face in very challenging context, especially if you are living in economic hardship. There's challenges to reconcile there. If you are in a context where there is extreme gender inequality in terms of your role in society, and that is not the case across the board, but, you know, there are some context. Religion plays a very interesting role in some contexts, about attitudes and beliefs about sexuality, and so I think it's a very complex conversation, and I think, you know, there's always that disconnect between knowledge and practice, and I think that's, again, the where the gray area is. You can know a lot, but there's certain things that may impede your ability to practice your, you know, and act out and play out the knowledge that you've gleaned or gathered. And so, yeah, I think that's how I would answer that question.
Next question, Bavmundo. Is the myth that having sex with a virgin will get rid of HIV/AIDS still prevalent? If so, how is public education carried out by Stephen Lewis Foundation on that?
I mean, I don't know if that's a specific myth or if that kind of gained popularity in the Western media in terms of the perspective on Africa and why there's a spread of HIV and AIDS. I mean, I think it may be it's hard to generalize really in terms of that specific thing. I think that, again, there exist in many areas of the world, but in many communities, Africa is no exception, and the countries that exist there are no exception. Myths and misconceptions around HIV and AIDS. Many of those myths and misconceptions, I wouldn't say that they no longer exist, but because of the work of community-based partners and all of the tremendous progress that's been made, we are very clear about the medical aspects of HIV and AIDS. We're very clear on how you can contract HIV, and what, you know, you can do to prevent HIV, and what you cannot do to prevent HIV. So I think that these kind of HIV 101, as I'd like to call them, you know, that information is more readily available, more easily accessible through community-based partners, and I think that there is probably more of a sense about the kind of biomedical aspects of HIV, right? I think, again, that gets blurred around particular cultural context, and kind of localized context, and those differ from place to place. So it's really hard to generalize about one specific misconception because it may not exist across the board, and but we know that they exist. So that some misconceptions about sex and sexuality continue to exist. So.
Laurie Schultz, I understand some of the home-based care partner programs were very effective. Some were providing training for home-based care workers as well as their wages. Is this continuing?
Yes, I mean, home-based care has become so much more expansive. It's essentially a part of wider community-based care systems. And so, many of the partners that we work with, I'd say the vast majority, have some component of community-based healthcare built into the work that they are doing, whether that be, coming to their centers or physically going out into the community to do this work. And so, yeah, we continue to support this work because it's so key for so many different reasons. And I'll say, especially in the context of now COVID, I think like going into folks' homes and their places of comfort has been a real eye-opener in terms of understanding what's happening in the family that may be affecting individuals. And so I think that this work continues to be really powerful because it is that human connection piece that really is the heart of this work, forging meaningful connections with other people and building that trust with other people so that people can feel comfortable and confident in you and in your intentions and can have a better understanding of some of the support systems that are there to facilitate their health and wellness. So yeah, we continue to support this work 100%.
Next question comes from Knut Peterson. Thanks very much for your presentation. Is there evidence that HIV/AIDS infected persons are particularly at risk from COVID infection, more so than others that are immune compromised?
I don't want to speak on it. I don't have that information. It's not something that I've been made aware of, if it is the case. So I don't know if I can answer that question meaningfully. I don't think it's something that I've been made aware of.
Next question comes from Laurie Schultz. Have the African governments taken any effective initiatives regarding sexual violence? And then in brackets, education, justice, etc.
Yeah, I mean, a huge question because, across the 15 countries that we work with, the context, the political context is all very different. I want to say, that, many countries have bought into things like CEDAW, the Convention on the Elimination of Discrimination against all forms of violence against women. And so there is an obligation and a responsibility and a legal responsibility for governments to have policies and practices in place that support ending violence against women, whether that be through the legal system and the justice system, protection orders, I mean, those kind of things. But I mean, how it plays out in real time is always very different. And I think, I just think it probably really differs from place to place. I want to believe in best intent and that, that there are a lot of good people try to do a lot of really positive things. But when the need is great, the challenges are immense. So I think, the role that community-based organizations play is really kind of stepping up and filling some of those gaps. And the hope that is that, these kind of gaps get smaller and smaller and shorter over time. But, I think that's the role that community-based organizations have a vested place in, is filling the gaps that are left in a response, in a national response.
Beth Mundell, in which countries are you seeing hope for more gender role equity?
I would say, that's a big question, but I feel like in all of the countries that we work, because of the work of our partners, there's been, tremendous progress, and when I share this presentation, I don't want her to think that there's not been tremendous progress in many of these areas. because I think that the role that community-based organizations have played is that public education, is that psychosocial support, is access to legal redress, access to paralegals. I mean, the list goes on in terms of the roles that community-based organizations have played in kind of supporting better understanding of gender equality and inequality, what constitutes to it, and how you can work towards greater gender equality in your families, in your communities, at civil society levels. I think that there's been tremendous progress, especially as it relates to the role of women in these spaces. And no more is it more evident when you look at some of the communities we're with and who's there doing the work. So there's been tremendous progress, but there's still much to be done. That doesn't just exist in sub-Saharan Africa, that exists across the world as it relates to women's rights and women's access to equal pay, to be free of violence. In the case of Canada, when murdered and missing Indigenous women, So I think that we all have, in every country of the world, there's a lot of work yet to be done in this regard. Again, it's about,
Laurie Schultz, what strategies or campaigns is the Stephen Lewis Foundation using to bring the realities of HIV and its impacts on generations of families in Africa to the other countries?
To the other countries across the world, you mean?
Yeah. So what strategies or campaigns is the Stephen Lewis Foundation using to bring the reality of HIV and its impacts on generations of families in Africa to the other countries? I'm assuming, yeah.
Thanks, Laurie. Yeah, I understand. Thanks for the question. We're putting up quite a lot of information at the moment, actually, and one of the exciting bits of my role, actually, which is new, I've been in a few roles at the foundation, is really translating the learning that's coming from the partners and sharing that with our international community more meaningfully, so that you can see the work of the partners more meaningfully. We're really excited to have that process kind of underway. It's a big part of our new strategic plan as well. So yeah, I think we are continuing to work to amplify the voices of the partners. Again, we're not taking ownership for this work, but this is partners' work. We want partners' voices to shine through. And so we're continuing to have initiatives around amplifying partners' work, amplifying their voices in this space, talking about the things that matter to them, being able to answer some of these questions that are specific to country context that only they can answer, right? And so, we're continuing as a foundation to prioritize that through our campaigns, through our initiatives. We have a new one that's responsible for advocacy, so we're going to be taking a more strategic and deliberate role in advocacy. And so we're really excited about that.
Next question comes from Mark Goddell. Does antiviral treatment in infected pregnant women prevent acquisition of HIV in the unborn child?
Yeah, and in terms of mother-to-child transmission, I think a lot of countries actually have done tremendously well. That's one of the areas that many countries have done tremendously well in, is in mother-to-child transmission of HIV. And that is through, the use of antiretroviral medication and catching HIV in its early stages. And so I think there's more supports that are required around that, but it's a big part of what our partners do. We have a partner in Lesotho called M2M, Mothers to Mothers, and it's primarily based on mothers reaching out to other mothers and mother mentors, supporting women living with HIV and AIDS who are pregnant, and understanding what that journey looks like for them, how to prevent their children from contracting HIV and AIDS, and how to kind of walk that journey.
Our next question comes from Knut Peterson. Given that most people around the world, irrespective of social status, have access to the internet and social media. Have you seen a difference in more awareness this past couple of decades?
More awareness of HIV and AIDS, and yeah, I would probably say that there has been greater awareness. I would say that the conversation is not nearly as much around awareness as it is around action. So many people are very aware of HIV and AIDS. They're very familiar with, how to contract it, how to prevent it. And again, a lot of those kind of biomedical aspects of HIV and AIDS are very well known. I think, but then there's the disconnect of when, as they say, when the rubber hits the road, right? How does knowledge translate into practice and behavior change? I think is an ongoing challenge in aspects of work, of our work. And so, yeah, I would say that there's definitely increased awareness around it. Has that reduced stigma to some degree? Is there still discrimination? Yes. Is there particular social attitudes that exist still that are prevalent about people who are living with and affected by HIV? Absolutely. Especially if you compound that with other components of people's lives, whether they be the LGBTIQ or sex workers or injecting drug users. And so, the stigma still exists around those spaces. And so, yeah, again, I think it's about this. It's more than knowledge, right? It's about it's more than knowing. It's a being able to bridge the disconnect between knowing and the practices that create enabling environments for folks, whether that be healthcare workers, making sure they're not discriminating against people living with HIV and AIDS and their knowledge about it, and putting that knowledge into practice because of their own personal value systems and belief systems. This really is a personal belief and value systems thing. You can know a lot, but if you don't internalize that, then it becomes a very different conversation.
Our next question comes from Ian Hurrell. Even in our society, the grandmothers that are being parents seem to have the ability to tell persons selling false information or promises to get lost. I'm sure they do even better in Africa.
Maybe. Thanks for that question. Yeah, I think the grandmothers are an incredible force, and they've created some really, and continue to create really meaningful and lasting changes for themselves in terms of acknowledgement of everything they've done in community, and that they're continuing to do in terms of lobbying for access to their rights, to land rights, to social protection, to pensions, to decent standards of life that can support them and their caregiving responsibilities.
That was our last question. So before we wrap up the session, do you have a take-home message for our viewers?
Yeah, I think my take-home message for everyone, and thank you so much for tuning in. I really appreciated being a part of this conversation with you, is that, while tremendous progress has been made, there's still a lot of work to be done. And I think that countries across sub-Saharan Africa continue to feel the inequality that larger global systems continue to impose upon them. And this vaccine issue has been no different in terms of access to vaccines as it relates to COVID-19. And I think if some of these issues were happening somewhere else in the world, there'd be a lot more attention, there'd be a lot more funding available for this work. But for some reason, that's not the case. And I think we really need to unpack and explore why that is a bit more as a community, and think about why that is, and how we can support the work that's already happening on the ground and the folks who are doing this work day in and day out for the good and betterment of their communities and the people that live in them.
Wonderful. Thank you so much for your presentation today and for joining us. And folks, for next week, I hope you'll join us for Dr. Paul Parks Access block, what is it? And what are the challenges facing the Alberta healthcare system? And thanks again, Leah, for today.
Thank you. Thanks, everybody.